There's a lot that we could talk about. I'm going to skim through much of it and try and stay on the core topic of this talk. But if you want to ask me any questions, my email address is here on the first slide, down on the bottom right here, daryl@intelms.com. And I'd be happy to try and answer questions off this webinar for anything I don't cover in any depth. So essentially, the system we're going to talk about is something called Bluebird, which has been used in Southern Africa now for more than 2 decades. And it was developed essentially initially as a communication hub. And what, as Nikki said, was made to be secure by design, really on the back of the HIV experience. So it started live in 1995. Within 10 years, we were invited to talk to the American College of Family Physicians in Dallas because of the sort of groundbreaking work we'd accomplished back then already. And by 2018, we had more than 200 ICUs, including the largest ICU in the Southern Hemisphere, running on this data hub, getting all their ICU results. And that was really important to ensure that the results were available in real time. And that's part of what we do that's relatively unique compared to many of the other people doing the same thing. Today, I think we're much more known by the systems, the electronic health systems that we provide for large hospitals and now nursing homes. This has been featured quite well internationally. There's a link to this welcome video that talks about. So this is the web interface, which is not really what I'm going to spend much time on today. The use case here is really moving lab results to the Department of Health. But I just want to touch on why we were chosen to do that. So this slide, I did a talk for LHSN back in October of 2018. And if you just look on the right side, you'll see that part of what we do now is we produce for all the significant multi-drug resistant isolates, and we've added COVID-19 to that at the beginning of this epidemic, although obviously it's not exactly a multi-drug resistant isolate, but for all the rest, and now COVID-19, the system can look regionally and then drill down right to individual hospitals throughout South Africa. So we can know what the MRSA rate is at any province, any region, any sub-district, right down to a voting level. And we can do that on the fly in real time by any of these significant multi-drug resistant isolates. As I said, where I'm going to try and confine the cyber part of this talk to is the APIs we use to get data from the labs, to put them in this vault that we keep on the cloud, and then to make that information available via another API to the Department of Health's data lake. The web interface, the security of that, I'm not going to spend a lot of time on. Quasi is going to talk a little bit to that. So part of the tools we provide the Department of Health is the ability, for instance, to use a web interface to look in real time where these cases are in the country. So the bottom part of this slide really shows, there's a slider here, it's cases per 100 population. And depending on where your Department of Health wants to set that, you can look at the regions right down to a voting district that are above that critical level. So for example, that's what Madrid's just used last week to shut down certain portions of the city. I mean, this functionality, not our app, obviously, all through the web interface. And then one can drill right down to a very granular geographic level and see the hotspots and exactly what's happening. And then it also collects all the hospital data, so we can look at hospital capacity. We can see, how many ICU beds there are, how many patients are on oxygen, how many patients are using high flow nasal cannulas, what our PPE level is, either by region or right down to individual hospital. So again, I'm just giving you that for completeness. It's the stuff above the line that I'm really going to talk about. As part of that web interface for the Department of Health, we also capture all individual patient information. So, for example, we know patients on an individual level what their comorbidities were, what their symptoms are, and how those change with time. And there's an ability both to allow that data to be entered through both a mobile application and any sort of web-based application, as well as we have APIs for other third parties. So for example, in South Africa, there are a couple of very good applications running through WhatsApp that allow patients to have their symptoms updated in real time. And the contact tracing gets done by that, and confirming patients' addresses because they can drop a pin on their home location and things like that. So that's very powerful. We've got APIs that bring all that data into Bluebird. And then all the hospitals in the country can also send through data at their choice. I mean, they can opt in or out of this, but obviously we try and encourage them all to opt in. And they can send all their data through to the Department of Health through the same interface. This next slide just shows hospital data, and that's what Kwadzi is going to talk about. So on the left, you can see hospital capacity data. This takes about 20 minutes a day to fill in on a web form that's part of a secure service. And on the right, hospitals like Nelson Mandela Children's Hospital and many other premier hospitals in South Africa are actually using the electronic health part of Bluebird to record on an individual basis everything that happens to that patient in the hospital, and then move that data through to the central hub. That web access, the user access there is via that hospital's Active Directory, and we give two paths to that. The top one, which is the one that Nelson Mandela is using, where the user types the username and password of their system, of their hospital system. In Kwadzi's case, it's an SAP system. And then through a web service, we authenticate that user actually has access to their AD, and then we let them into Bluebird. The Department of Health rather uses an OAuth 2 and OpenID Connect system, so certificate-based, rather than a username and password, but to do the same thing, to authenticate against their Active Directory. So don't worry about this. This is just how we've implemented OpenID Connect with the Department of Health. So what I'm going to ask Kwadzi to do is just talk about how the usernames and passwords are protected in the hospital's Active Directory, because obviously we don't control that. And if users are cavalier with their username and password, or they share usernames and passwords, that really is probably the biggest potential weakness in the system. Okay, so Nikki, if you don't mind, I'll hand over to Kwadzi.
Good morning, everyone. So I'm having some minor technical challenges, but tell me as soon as you see my screen. Daryl, can you see my screen?
Kwadzi, I can't yet. That's starting now. There, I've got it. Yes, I can see.
Oh, okay. All right. So Nelson Mandela as a client for as a client of Bluebird, we have to establish a strict boundary of trust. So that strict boundary of trust means that we have to take into consideration all the external and internal threats which exist, both in our internal network as well as from the internet side. So to do that, we have to implement a zero trust policy, and this zero trust policy is applied on the credentials that the users are going to use, the location from which they're going to log in from, their device health, as well as the risk factors which are out there. Also, we have to segment our network. The segmentation of the network is done so as to control access to the entire Nelson Mandela network, to improve our monitoring of the network, as well as to contain any form of malicious activity which might occur on the network. So what it means that if a problem occurs, for example, in a segmented network in the DMZ, it will not affect the rest of the network because it will be segmented. The other aspect we have to deal with is the identity and verification of the controls of the user access using controls on Active Directory. So this includes strict password policies, which include password length, password expiration, and password durations. Also, we have to use multi-factor authentication so as to ensure that we verify all the users who are logging onto our system. User training needs to be done in the form of IT security awareness so as to ensure that users are aware of the various threats that are there and can assist in securing their credentials. So Bluebird doesn't have a lot of requirements post implementation. So the initial requirements that are required for on a client basis, on a client side, is the setting up and the integration of Bluebird with the customer's systems. These systems are the Active Directory for the user verification, as well as the HIS, which is the Hospital Information System, which pushes data to Bluebird. Once implementation has been done, there is minimal maintenance that is required from a client side. From the client side, the main responsibility will be the verification and maintenance of the device health, so as to ensure that no attacks comes through the devices which are connecting to the Bluebird system. As a client as well, we're supposed to have effective backup and restore procedures so as to minimize any form of disruption which may be caused by any attacks which occur. And lastly, the users are supposed to be trained on the use of the Bluebird system as well as for any other improvements which occur on the Bluebird system. I'll hand over to Daryl.
So thanks, Kwazi, really appreciate that. Let me see if I can get back now onto my talk. Sorry, now I'm having the same technical challenges. Just bear with me because I don't want to get onto the wrong talk. Can you see my screen again, Kwazi?
Yes, I can.
Great. Okay, so thank you very much for that. Generous of you, Kwazi, to say all that. Just the one thing I want to add is that when you talked about backup, that means backup of your systems and your Active Directory and that. So backup of Bluebird is obviously done as part of our cloud service, and I'll talk briefly to that later.
Yes.
All right, so again, as I say, there's a lot that we've done and a lot I'm not going to talk about. So for example, this check-in app that we've produced for restaurants for the Department of Health to use, I'm not going to talk to. Essentially, the data pipes bring in all this other information. So Kwazi alluded to information coming from his health information system. It also comes from hospitals, pharmacies, from their operating rooms, from their EMRs if they've got one, or their electronic health records, if they're using those in conjunction with Bluebird, and from devices. And in terms of COVID, we've talked about the symptoms and contact tracing information that comes in as well. But for the purpose of this talk, I'm really going to confide it to lab details. So all this information comes trundling down the fiber optic to us. And having done this now for almost 30 years, I think we are considered experts at this. But the important part to me is that we actively manage all of this information. So if you look at that little icon here on the left, everything that a lab thinks they've sent, we confirm is actually in the end user database. And if anything goes wrong, and it's quite a complex process, which I'll try and unpack now, if anything goes wrong, our staff who are on call 24/7 are notified immediately, and they will act to address that problem, typically, within minutes, and very, very seldom will the end user ever know that there was an issue. The system's complex, there always are issues, but the way we actively manage those issues and resolve them, I think is why we've managed to do this quite well over a long time. So just to recap again, all we're going to talk about is the lab and the multiple labs, so multiple APIs, going into the secure vault on the cloud, and then that data being taken out by the Department of Health. And that all happens in real time. There are many, many moving parts, as I'll show you now. And that's led a lot of people to underestimate how hard this is to do. And you have to just look in the lay press almost any week in the last 2 or 3 months, and you'll see systems that are causing problems. So this one I just took for the purpose of this talk. I'm not picky on Iowa, but they just happened to come into the news on the day that I was putting this together. But the National Institutes of Health, the state of California, Quebec most recently over 2 weekends ago, all of these systems have had major hiccups, and it's not nearly as easy to do and to do at scale in a robust manner as people think. All right, so to start off with, data capture happens at the lab, typically in a lab depot. And one lab might have many, many, many depots, and there's different levels of skills at those depots and multiple lab information systems. And unfortunately, many of those don't do any validation on data capture. So part of what we've done for the Department of Health, and I'll show that in a later slide, is to try and help them improve feedback to the labs to help them improve data capture. So for track and trace, we really want to know the patient's mobile phone, and we want to know their home address. Okay, so the labs send all this data through to the APIs, which I'll go through in a second, into the Bluebird hub. Out again, the Department of Health polls this data through another API. And then in our case, that data is made available to our national telecom, and they are responsible for sending SMSs to the patient, alerting them to their positive results, and bringing them into the track and trace system. It's obviously important that data integrity from the time a lab sends something to the time it ends up in the Department of Health, one needs to know that nothing changes. This is personally identifiable patient information, so the data security is critical. Labs all on different systems producing different formats of data, and so data normalization is a big, big part of this. When we started this in the 90s, before there was a lot of the labs joined forces, I think there were about 100 different labs that we had to integrate with. Now it's down to about 20, but 20 of all different systems is still significant. And then the system has to be massively scalable. So the Director General of Health in South Africa was quite astute when putting this together in the first place. When he got us to sign our initial contract, they ensured that we undertook to make it massively scalable. And in fact, about 3 months ago, one of the bigger labs had an IT problem and started sending out literally hundreds of thousands of results, duplicate results in a day. And so we were getting like 500,000 results a day. And the system coped with that only because we'd been forced to plan for that with our contract. So the system is massively scalable. And I just want to say one more thing. I meant to say it on the slide where everyone thinks this is easy. In South Africa, we were contracted to get involved in the emergency situation of the COVID epidemic while government systems that had already recently been put into place underwent sufficient testing. So we were given a 6-month contract to do this for them. And in that 6 months, the two systems were run in parallel, and any differences between the two were immediately investigated. And that enabled the government systems to be very quickly scaled up to be able to do this themselves. And our contract will end, I think, in the middle of next month. So everything on these secure communication channels is built using a transport layer security, which is really the latest iteration of SSL, which most of you will probably be more familiar with. But that TLS provides both authentication, so you know who's sending to who, as well as the data encryption. And the actual system is quite complex. I'll try and sort of skate over the top and try and answer questions if people have got more detailed questions later. But it begins with a TLS handshake, and that really is exchange of the two users' public keys. So there's public, there's asymmetric encryption, which is public and private keys, and it also uses symmetric encryption. And the reason for the two is the first one's more secure, but much more resource intensive. The second one is slightly less secure, but much less resource intensive. So the handshake's done using the asymmetric keys, and then the session keys or symmetric keys are generated, and that allows the encryption in that session to happen using those expirable session keys. And that whole secure channel runs on top of TCP, and TCP provides reliable, ordered, and error-checked delivery of each byte of data. So this is what's commonly referred to as HTTP over TLS, or as you've seen in all your banking sites, HTTP with the S. Over the years, all of these things have had to be put in place. So we've got documents about access control, their secure administrative tunnels using SSH. We've got a guard against malware and spam protection. Each build of the product's got to be secure. We prioritize security fixes, so we prioritize keeping up to date with the software, making sure all latest security fixes are installed. The architecture is highly resilient, and every component is redundant. There's load balancing in place. We've got specific policies for incidents and breach management, and obviously capacity management in terms of making it scalable. Now, all of these are almost talks in themselves. What we have produced is a document. I know this is going to be very small, so I'll just pick on some of the highlights. But we publish how we do all of this. So from staff training that Quadzi was alluding to in his organization, through how we cluster the database, our firewall, the rules, intrusion detection, how we secure the SSL servers, how we maintain the database. So all of this is documents and available. And if any of you are interested, I mean, if you set up your own systems, this is quite a nice guide to what's needed, and I'm very happy to share that with anyone who emails me. In terms of data coming in, our preference is that we use XML over a web service. Now, I say our preference because remember, we have to connect with every single laboratory in the country that does COVID-19 testing. We also connect to the vast majority of the laboratories generally because they supply the hospitals with data. But in terms of COVID, the mandate we were given by the Minister of Health is that every single laboratory that does COVID testing has to send data into Bluebird. And our preference is this XML Web Service. But remember, because we have to connect every lab, even the ones, they're labs with unbelievably great IT capability, and they're very small labs with minimal IT capability, and we've got to connect them all. So while we prefer certain ways of connecting, we have to cater for the smaller ones that don't have that capability. So our preference, again, is a web service. And the thing about a web service is that it's authenticated by the person connecting, so we know who's sending us data. And that's part of why we prefer that. We also, so we accept data over XML. We also accept it via HL7, and the vast majority of our, not the vast majority, but the majority of our results actually come to us from HL7 from the government labs, which is the biggest lab service in Southern Africa. And that can either come through to us via a web service, which all the hospitals use, like Quadzi's hospital will use. But the government lab actually doesn't send it to us on a web service. It rather sends us in a more traditional form of HL7, which is something called MLLP. And that really sends data over TCP in a continuous stream of bytes, but it does have header and footer information to allow us to break out those bytes and bundle individual results. And there's an acknowledgement of each message in that, which is very similar to the previous slide, but in this case, using an HL-specific acknowledgement. All right, now this is the nuts and bolts of what I want to talk about. This slide's the important one, and I'll spend quite a lot of time on this and come back to it during question time, because I think this is where the questions might well arise. So we have some form of TLS service that brings the data into us. So the data stream is encrypted. So think of it as a secure host pipe sending data from the lab to us. But how that TLS service works is different. We prefer a web service, but for instance, there's small labs that have no ability at all to even make a connection, a secure connection to us, let alone set up a web service. So for some of those ones, we'll actually provide applications that run on their servers, which will poll a directory. And all they'll do is drop their data files into that directory. We'll pick it up, we'll encrypt it, we'll open up the tunnel, and we'll send it through to us. And as I said, different labs, we've got to deal with whatever format they are able to produce. So we publish the format we prefer. And but in essence, in practice, we get more than one different type of format. So we have incoming directories. In this diagram, I've shown it just as one directory, but we actually have incoming directories for the different types of XML that we accept, as well as for HL7. The uploading service itself will look at major errors in the data that we've been sent. So for example, if there's no routing code, so we need to know where to send that data when it arrives at us. So it might go, for instance, to Quad's hospital, or it might go to the Department of Health, or it might go to an individual doctor, and so forth. So the lab has to put on the routing code of who they want that sent to. And right at the beginning, during that uploading process, if that routing code is missing, we'll bring up an error. So all of these blue bars at the bottom, these blue arrows, are errors that are picked up, put into an error directory. That error directory is monitored in real time 24/7. If there's an error that hits that directory, immediately an SMS is sent to our on-call IT staff, as well as a backup email, and they will immediately address that issue. So for example, if it's a lab that hasn't put on a routing code, they'll pick up the phone, they'll speak to the lab, they'll explain exactly what's going on, they'll get the lab to resend that information with the right routing code on it, and so forth. Similarly, as the information arrives in, let's say, an XML directory, it'll make sure that the XML is properly formed. So that's one of the ways of us making sure that the message has the right data integrity. So if the XML isn't properly formed with opening, closing tags, etc., that file will be picked up, put into the error directory. Then we split. So typically the lab will send us one big XML file with multiple individual patient results in them. So we'll split that into each individual patient result XML for each individual report. And we'll also normalize the data. So whatever format it arrived in, we'll normalize into a standardized XML format that we internally call the Bluebird XML format. And again, if the data is not well formed inside there, if the split data is not able to be opened properly, it'll generate errors and we'll deal with that. Then once it's each individual lab reports, that there's header data in that tells us who sent it, who it's for, what time it was sent, what the lab ID was, and what the Bluebird ID was. And all of that information is broken up into another SQL database. And that one's used to track, so we know at any time where every single report is in the system. We also have implemented something we call watchdogs. And if you think about the smaller labs, they might not send information for several hours. And the problem with that is we have no way then of knowing if the lab's up or down, and labs have their own IT problems. So what we've got them all to do is to implement something that we call a watchdog. And that means periodically, typically every 2 hours, the lab will send us a message. And that message we track, and if we don't get one for longer than 2 hours, it creates an alert in this tracking system. And again, our staff get onto it, phone the lab, find out what's going on, help them get their systems back up to speed. Obviously, the bigger labs are sending data, they almost never go for 2 hours or even an hour without sending data, and they do it right through the night, especially with the COVID epidemic. So the watchdogs are less important for them, but still we found use for it. The second thing is we also look at when the last message arrived, and if we haven't had a message from any of the big labs for more than 2 hours, again, we create an alert. In terms of the Department of Health, we got burnt a little bit early on, where a big lab was sending results out, but only to the hospitals and doctors, and not their feed to the Department of Health had actually failed. And we didn't realize that, and we didn't pick it up because we were still getting data from them for hospitals and doctors, but not the COVID data for the Department of Health. So we sort of upscaled that, that monitoring, and we actually break that into 2 streams. So if we don't get a Department of Health message for 2 hours, again, from any major lab, we'll immediately investigate that and find out if the lab's down. Again, any errors in that process get tracked. And then we've got to insert the information into our database. And again, if there's anything that goes wrong there, that error would get tracked. Once the data is in our database, we break it out into a second database, just key data. In this case, it's who the sending lab was, and it looks at cell number capture, patient address capture, and patient ID capture, because that's absolutely important for track and trace. So we look at that and we color code it. You won't see it, there's a tiny diagram on the right here, but you can see it's mostly green. And if they fall below certain levels, then we can do this right down to a depot level at the lab. So we can turn around and say to one of the big labs in South Africa, listen, your depot at this little village is really not picking up the cell numbers, or not recording the cell numbers of patients. And then the Department of Health can put somebody on that, they'll go and speak to that lab will follow up. And by doing that sort of thing, we've really improved data capture by the labs dramatically over the course of the 6 months we've been involved. After this process has gone all the way through here, the data file is kept in a done directory. We just happen to call it done, and it's kept for 4 days, just in case anything goes wrong in the process. We can still revert to this done directory for 4 days and see the original report that came from the lab. And then as a belt and braces thing, we actually also store it in the database forever. Briefly on the way into the data with the HTTPS, I showed you how we protect data in motion that's coming through those data pipes. But the whole system also is encrypted at rest. So we use Linux boxes, and Linux has something called LUKS, L-U-K-S, which is the standard for encrypting hard drives in Linux. So that means that even if someone could break into our data centers, and we have data centers in Cape Town, and we also use Amazon Web Service data centers also now in Cape Town. But even if somebody broke in and took the hard drive, they couldn't do anything with it because it's encrypted at rest as well. Backups, so at the moment we're running backups ×4, which is obviously desperate overkill. Part of that is not just because we're trying to be so careful, but as we've upgraded the scalability of the system, we've still got all our legacy backups in place. So right at the beginning, we would back up across town. So we would zip the database every night at 12 o'clock, send it across town to another facility. Then we, as we started putting on all the state hospitals, and the system did start slowing down, which we anticipated, we moved all of those hospitals onto Amazon Web Service in Cape Town. Luckily, they just opened up the Cape Town facility at the beginning of the COVID epidemic. And then we started moving all the Department of Health information across to that backup. And we do that with, as those data pipes come in, we've written a splitter that every bit of information, so it doesn't only go to these incoming directories here, it also goes to directories on the other service across town on Amazon Web Service. So that's a fully functional duplicate and fully backed up. And then because we were planning on moving our whole system onto Amazon Web Service anyway, not just the Department of Health system, we're also replicating our legacy database in real time across to another instance of Amazon Web Services in Cape Town. So we're sitting with 4 backups at the moment. The wonderful thing about having them duplicate on Amazon Web Service, even though the Department of Health is still using our legacy systems because they've worked really well and there's no real reason to change at the moment. So the other 2 are sort of just spinning their tires, but they're available literally within seconds. So if something happens to our main system, we can switch to either of the 2 Amazon Web Services, and in a last resort, we could also go and have a zip backup that's at another server across town on a completely different installation. The nice thing about Amazon, though, is that ability to just switch from one instance to a replica instantly, and we can even keep those replicas in different geographic regions, even geographic regions of the world, We don't do that just because of data residency requirements in South Africa. So we keep all our data inside the South African borders. But if we were asked to do it, we could certainly have that data replicated. We run Amazon Web Services in Sydney at the moment, and on the west and the east coast of North America. So backup and disaster recovery is really done, I think, really well. That's all I want to say on that slide. So yes, this is another important part. So remember I said that every result that a lab thinks they've sent, we make sure that it actually is in the database. So, and we do that because part of our protocols is that at midnight every night, or just thereafter, every lab sends us a CSV file of every single report that they think they've sent to us during the last 24 hours. And then we have an automated process that looks and makes sure that every single one of those reports is actually in the Bluebird database. And again, if the one that isn't, our staff immediately are notified 24/7. They'll get hold of the lab. They'll say, listen, we didn't get this lab ID number. Please could you resend it to us? They'll confirm it's resent and in the database. So again, the end user never sees any of that complexity. All they see is a system that just works flawlessly. And it's a little bit like that, old story of a duck paddling furiously underwater, but on top you just see this beautiful placid scene. So our staff spend a lot of time and effort making sure this all works as flawlessly as it looks to our users, but there's a lot going on underneath. And then how does the Department of Health pick up this information? So they use another HTTPS web service that we provide. They authenticate with their username and password, and we've also provided them with an OAuth and an Open Connect certification way of connecting. And that password is, if they use the username and password, which is what they have been using up until very recently, that password gets changed periodically in conjunction with the two of us. And then they poll that data by key, so they poll it, and then they'll poll to that key going forward again. And that standardized data comes to them in a JSON format, and then they can break that out into their own data lake and supply it to other third parties like our telecoms. Again, we want to double check everything. So we also have a Unix shell script that runs on our side that makes it look like it's a user of this web service. So it goes in and it looks at the last report available and makes sure that it's not older than 2 hours. So again, because so much data is coming through this system, I mean, the COVID data is coming through, it almost never is for more than 10 minutes that we don't get a report, even in the middle of the night. So if there's a report older than 2 hours, if the last report that reports is older than 2 hours, there's something wrong. And again, our staff will get alerted, they'll investigate, and they'll fix it again, hopefully before the Department of Health picks that up in the morning, usually at 7 o'clock. Just to again, and right at the beginning when we first put this into place, there was one day where we went 2 days where there was a problem on this service, and the Department of Health notified us on the Monday morning. And so we put in all the automated checks, and we worked out why the automated checks we had in place hadn't worked. We fixed them. But then on going forward, which has now happened for the last 4 months, staff also manually at 6 a.m. every morning, and I think about 11 o'clock every night, every day of the week, including holidays and weekends, one of our staff members will go in and just manually confirm that this is all working as expected, even if we haven't had one of the automated notifications. I think that's all I want to say. I'm not sure if I've got time, Nikki. I can carry on or stop now. Maybe it's best that we leave some time for questions. What would you like to do, Nikki?
Yes, we've had a couple of questions through the chat, so potentially maybe if you just have some summary comments now, and then we have 10 minutes to go through those questions.
Okay, so I'll just quickly show the last 2 slides. So this is just an example of the watchdogs, and you can see that there's an interface that if any of these were not green, it would have sent out a notification to our staff. And similarly, this is how every single message is tracked through the system. So in summary, Bluebird is a private company, or the Intelligent Medical Systems that own Bluebird is a private company that's been active in Southern Africa for the last 25 years, moving data in the medical, between laboratories, hospitals, doctors, and now the Department of Health. And although our work now is really mainly in electronic health systems, particularly aimed at infection control and antimicrobial stewardship, we had this data hub capability at scale that could provide an instant solution in Southern Africa for our National Department of Health, so they could spend the 6 months getting all their systems absolutely bomb-proof. And they're just about there now and about to take over from us, and we'll go back to doing our sort of usual core business probably at the end of October. And that's all I've got to say. I think, very nice of Kwadzi to join me. He's been a fantastic person to work with over the years, and I really appreciate him coming and helping with this talk as well. I'll take any questions. I'm sure Kwadzi will as well. Over.
Great. Yep. So first of all, I can ask you what's come through in the chat. And if there's anybody who hasn't yet had the chance to ask a question to me directly, you can go ahead and do that now while Daryl and Kwadzi are taking the existing questions. So the first thing that came through is, what is the adherence rate of daily COVID reporting among hospitals in South Africa, and is it mandated? I think that might be a question for Daryl.
Sorry, I'll just get myself off mute. Yeah, I think that's a great question. And in fact, it's a question that's very political. And I think that's really what you're alluding to. It's poor. And in fact, the Department of Health is using that much less than the systems available to them. And I think part of it is the split between private and public systems in Southern Africa. Plus, every province is essentially autonomous, and they've shied away from mandating, which would have been my choice. And personally, I mean, I maybe shouldn't say this publicly, but personally, I think it was a mistake. I think the minister should have mandated that every hospital does this. And because the adherence is not very high, and I don't want to give the exact figure, I think that's confidential, but it's not high, and I think that's been a severe discrepancy, sort of hole, even in the face of having all this capability to really manage this epidemic at an individual patient level as well as it could have been other.
Great, thanks. I think that answers that question. Another one that came through for Kwadzi is that you mentioned the user training element of your work. Can you expand on this? So I think the question asker is kind of keen to know more about the training itself, who's trained, what format is the training. If you can give some more detail on that, that would be great.
Kwadzi, you might be on mute.
I can hear slight noise, Kwadzi, but you're not coming through clearly. Oh, no, that's you. That's you.
Okay. All right. So there are two types of training that are involved. The first type of training is the IT security awareness training. That's to conscientize people about the IT security issues that are there in their daily operations, which include working on Bluebird. Then the second type of training is the one that is done by Bluebird. So what they do is they just take the users through an operational manual on how they work on the system. And also there is another training called Train the Trainer, whereby we train internal users for them to be able to pass on the skills to other new staff members who will not be part of maybe the main training. So those are the two types of training that are involved.
Great. And would that be all staff at your hospital, or is it people that are in the IT department specifically, managers of departments who specifically?
No, it's only the clinicians, because they are the only ones who make use of this system. On the IT aspect, we have we just familiarize ourselves with the system requirements and simple troubleshooting. that is done, but the major training is done for clinicians.
Great. Okay, I think that answered that one. Thank you. And the third question and last question that came in so far is around the feasibility of rolling out this kind of system in South Africa in other sectors, so to speak. So the person with the question highlighted research sites rather than hospitals. Is this sort of system feasible in that setting?
Can I take this, Kwasi? Yeah,
yes,
so,
you can.
Thank you. So yes, absolutely. Remember, we rolled this type of system down to an individual doctor level. So it's hospitals, doctors, departments of health, long-term nursing homes. Very easy to do it to, so technically it's very easy to do it to a research center. The problem isn't so much, it's who owns the data and who has a right to it. So we feel very strongly, or contractually, we also feel very strongly that the data belongs in this case to the Department of Health, and that nobody else has access to it except the Department of Health. And if they want to pass it on to somebody else, like for instance the telecoms, we've preferred that they make their own APIs to the telecoms or to somebody else to do that. So as long as the research body has authority to get that data, technically it's very easy to make it available to them. Over.
Great, thank you. And just very quickly, another question has come in, and I think we should make this the last one just because I'm conscious people need to get on with their day, and we don't want to run over time. A question was, what are the biggest challenges for Bluebird in taking over the handling of the COVID-19 pandemic? Quite a general one, but if you have some sort of overarching thoughts on the challenges.
Yeah, so again, Kwasi, do you mind if I just take this? Because I think the first thing is that we've had almost 30 years of experience doing this now. So we were very well positioned, and a lot of the problems we'd already solved over the last 25, 30 years. So it wasn't terribly challenging as a whole. As we started getting into it though, there were a whole lot of smaller labs that had never really done results for hospitals or for doctors, so often little research labs, and they had to be brought into the system. So their IT capabilities weren't nearly as advanced, so it was harder to get them set up. And secondly, the actual data capture at the lab, I think, has been by far the biggest challenge. So if you think of every little depot scattered throughout the country, trying to, and for instance, the private labs, up until the COVID epidemic, were not really that interested in capturing the individual patient's home address, for example, or cell phone number. They were quite understandably much more interested in capturing the person who's guaranteeing the bill. So for private labs, that was quite a change for them. But I must say they did that enormously quickly and unbelievably successfully. If you look at that validation that we do for all the labs, the private labs are all in the green. They're all well above 90%, most of them above 95% on all the parameters we measure. Some of the smaller labs in rural areas, the data capture has been the biggest challenge, I think. I think that's by far been the biggest. So not really an IT problem, but and that could be helped if those laboratory information systems were able to do validation on data capture, and I think they're all moving to that. I think I saw Sean Grimmett, who's the CEO of one of the biggest national laboratories in South Africa, and by the way, he's just been unbelievably good and helpful to us during this project. And I know he's been working very closely with all his depots, trying to make sure that data capture is constantly improving. I think that's it. Over.
Brilliant. Thanks very much, Daryl, for answering those questions. And thank you to everyone for joining us today on this webinar. It was really a very fascinating session. which we will now close. But just so everyone knows, an audio recording of the session will be available on our LHSN website and on our YouTube channel. So please keep an eye on your emails and social media for details of when that's released and of the next LHSN webinar, which will be held in late November or early December. And finally, a big thank you again to Darrell and Kwadzi, who took the time to take us through that presentation today.